Welcome to this ECG Masterclass. In the next few minutes, we will move from the fundamentals of the electrocardiogram to the interpretation of complex abnormalities. You will learn how to recognize normal waveforms, measure segments and intervals, determine the QRS axis, calculate heart rate, and identify rate, rhythm, and conduction disorders with confidence. The electrocardiogram or ECG is a graphical representation of the heart's electrical activity over time. It is recorded by placing electrodes on the skin which detect voltage changes as the myocardium depolarizes and repolarizes. The standard 12-lead ECG includes 6 limb leads and 6 precordial leads, providing multiple perspectives of the same cardiac event. This information is invaluable for diagnosing arrhythmias, conduction defects, myocardial ischemia, chamber enlargement, electrolyte disturbances, and drug effects. ECG recordings are produced on standardized graph paper moving at a speed of 25 mm per second. Each small square represents 0.04 seconds horizontally and 0.1 millivolts vertically. Each large square represents 0.20 seconds. The calibration mark, a 10 mm square wave, confirms the machine is correctly standardized. The heart's conduction system begins with the sinoatrial node, the primary pacemaker. Impulses travel across the atria to the atrioventricular node, where conduction slows briefly to allow ventricular filling. The signal then moves rapidly through the His-Purkinje system, activating the ventricles in a coordinated contraction. Understanding this sequence is essential for interpreting deviations on the ECG. The ECG consists of 5 primary waveforms. The P wave represents atrial depolarization. The QRS complex represents ventricular depolarization and normally measured less than 0.11 seconds. The ST segment represents early ventricular repolarization and should be isoelectric. The T wave represents ventricular repolarization. The U wave, when present, is associated with late repolarization and may be prominent in hypokalemia. Key measurements include the PR segment from the end of the P wave to the start of the QRS complex, reflecting AV nodal conduction delay. The ST segment from the end of the QRS to the beginning of the T wave. The PR interval normally between 0.12 and 0.20 seconds. The QRS duration less than or equal to 0.10 to 0.11 seconds. The QT interval corrected for heart rate typically less than 440 milliseconds in men and 460 milliseconds in women. The QRS axis indicates the general direction of ventricular depolarization. Using the quadrant method, if lead 1 and AVF are both positive, the axis is normal. Lead 1 positive and AVF negative indicates left axis deviation. Lead 1 negative and AVF positive indicates right axis deviation. Both negative indicates an extreme axis deviation. Heart rate can be determined by the large box method, 300 divided by the number of large squares between R waves. The small box method, 1500 divided by the number of small squares between R waves. The second method, count the R waves in 6 seconds and multiply by 10, preferred for irregular rhythms. Bradycardia is defined as a heart rate below 60 beats per minute. Tachycardia is defined as a heart rate above 100 beats per minute. Both can be physiological or pathological depending on the context. Common rhythm disturbances include sinus arrhythmia, variation with respiration, atrial fibrillation, absence of P wave and irregular RR intervals, atrial flutter, sawtooth flutter waves, ventricular tachycardia, wide QRS complexes with regular rhythm, ventricular fibrillation, chaotic baseline with no organized QRS complexes. First degree AV block has a prolonged PR interval. Second degree Mobitz type 1 or Wenke back has progressive PR lengthening until a beat is dropped. Second degree Mobitz type 2 has dropped beats without PR change. Third degree AV block has complete dissociation between atria and ventricles. Right bundle branch block has an RSR prime pattern in V1 with a QRS over 0.12 seconds. Left bundle branch block has a broad monophasic R wave in V6 and absent Q waves in lateral leads. ST elevation may indicate acute myocardial infarction, pericarditis, or early repolarization. ST depression suggests myocardial ischemia or reciprocal change. T wave inversion may reflect ischemia or ventricular strain. Tall, peaked T waves are characteristic of hyperkalemia. A systematic ECG approach includes 1. Verify calibration and speed, 2. Determine rate, 3. Assess rhythm, 4. Evaluate P wave and PR interval, 5. Measure QRS duration and axis, 6. Review ST segments and T waves, 7. Check U waves and QT interval, 8. Correlate findings with clinical presentation. While ECG is traditionally associated with cardiology, it plays an important role in physiotherapy for patient assessment, monitoring, and safety, particularly in patients with cardiovascular or pulmonary compromise. Establish a patient's resting heart rhythm, rate, and any conduction abnormalities before beginning physiotherapy interventions, which can help to identify underlying cardiac risks that may influence exercise prescription or respiratory care, specifically patients of arrhythmias or previous myocardial infarction. In cardiac rehabilitation, ECG monitoring ensures the exercise intensity stays within safe limits. It detects signs of myocardial ischemia early, preventing adverse events. In pulmonary rehabilitation, ECG helps track cardiac responses to exercise and prevent overloading compromised cardiopulmonary systems. Continuous ECG helps identify arrhythmias or cardiac strain during weaning trials in the ICUs. Also, during post surgical rehabilitation, especially after a cardiac or thoracic surgery, ECG ensures mobilization is safe. Physiotherapists working in sports or rehabilitation may use ECG monitoring to detect abnormal heart rhythms triggered by physical activity, guiding modification of training or rehab programs. Some breathing or airway clearance techniques affect intrathoracic pressure and heart rate. ECG monitoring helps confirm patient safety in high risk individuals. Physiotherapists can explain ECG findings in simple terms to improve patient understanding of their cardiac health and promote adherence to safe exercise guidelines. Thank you for joining this ECG masterclass. For more clinical training resources, subscribe to the channel and activate notifications. Share this video with colleagues and leave your questions and comments. Hey everyone, welcome to ECG changes in myocardial ischemia and infarction. Myocardial cells need a constant supply of oxygen and nutrients, which is provided by coronary arteries. Any narrowing or blockage of coronary artery makes it difficult to reach the myocardial demands, leading to myocardial ischemia. Factors responsible for this increased oxygen demand are faster heart rate, stronger contractions, and high blood pressure or ventricular wall stress. Transient ischemia during exertion presents as angina pectoris. Sustained severe ischemia can cause myocardial necrosis, presenting as myocardial infarction. Abrupt disruption in coronary blood flow, along with unstable angina, myocardial infarction, or sudden cardiac arrest, represents acute coronary syndrome. The diagnosis of MI is confirmed with ECG, cardiac enzymes, and other diagnostic tests. In this video, we will discuss the ECG changes which are seen in myocardial ischemia and infarction. The left ventricle is made up of an outer layer known as epicardium or subepicardium
and an inner layer known as endocardium or subendocardium. The impact of myocardial ischemia can be on the entire thickness or can primarily affect only the parts of inner layer. This through and through combination is termed as transmural ischemia.
The heart is supplied by two coronary arteries, the right coronary artery and left coronary artery. The right coronary artery usually feeds the inferior and posterior walls, while the left coronary artery divides into left anterior descending and left circumflex artery, supplying the septum, anterior and lateral walls.
As elevation myocardial infarction happens when a major coronary artery is completely blocked, causing full thickness damage to the heart muscle. Most cases are due to plaque rupture and clot formation. It shows up on ECG as ST elevation, often with tall T waves. STEMI evolves in two phases. In the acute phase, there is ST elevation and tall hyperacute T waves. Later, deep T waves inversions develop. The affected leads help identify whether the heart attack is in anterior or inferior wall of the left ventricle. Heart attacks usually affect the anterior or inferior walls of the left ventricle.
The ECG shows anterior wall Q wave infarction phases with ST elevation and reciprocal ST depression. The ECG shows inferior wall Q wave infarction with ST elevation and reciprocal ST depression. ST segment may be plateau shaped or dome shaped. Sometimes it is obliquely elevated or it may retain its unsloping appearance.
Pathologic Q waves form when an area of the heart muscle dies and loses its electrical activity. This causes the ECG voltage to move away from the damaged area, creating a deep negative reflection. Q waves typically appear within first 24 hours of the heart attack and help identify the infarcted region.
Anterior wall infarctions disrupt normal R wave progression in chest leads. Anteroseptal MI show QS complexes in leads V1 to V3 due to septal damage. Free wall or apical MIs affect leads V3 to V6. High lateral MIs show Q wave in leads 1 and AVL. Most are caused by blockages in the left anterior descending artery or its branches. The ECG shows anterior wall infarction. The QS complexes in leads V1 and V2 indicate anteroseptal infarction, and the diffuse ischemic T wave inversions in leads 1, AVL, and V2 to V5 indicate generalized anterior wall ischemia or non Q wave myocardial infarction. Inferior wall heart attacks appear in leads 2, 3, and AVF with ST elevations and possibly Q waves. They are most often caused by a blockage in the right coronary but can also occur due to left circumflex artery occlusion. The ECG shows acute inferolateral wall ST segment elevation MI with prominent ST elevations in leads 2, 3, and AVF as well as in V5 and V6. The reciprocal ST depressions are in lead 1 and AVL and V1 to V2. The ECG shows inferior wall infarction with abnormal Q waves and symmetrical T wave inversions in leads 2, 3, and AVF.
Posterior heart attacks are harder to detect because typical ST elevations don't show on standard ECG. Instead, reciprocal changes like tall R waves and ST depression appear in leads V1 and V2. Posterior MIs often occur along with inferior or lateral MIs, leading to terms like inferoposterior or posterolateral MI.
The ECG shows posterior infarction with tall R waves in leads V1 and V2.
Right ventricular infarction often occurs with inferior MI. Watch for neck vein distension, low blood pressure, and ST elevation in right-sided chest leads like V3R.
The ECG shows Q wave and ST segment elevation in lead 2, 3, and AVF along with ST segment elevations in right bicordial leads V3R and V1. A ventricular aneurysm is a bulging of the heart wall that develops weeks after a heart attack, usually seen in the anterior or inferior heart surfaces. The ECG shows anterior wall aneurysm with prominent Q waves and persistent ST elevations in leads V1 to V3 and AVL, and reciprocal ST segment depressions in the inferior leads. The persistence of ST elevation more than 2 to 3 weeks after an infarction suggests the presence of a ventricular aneurysm. Some patients may suffer more than one heart attack at different times. Old infarcts leave permanent Q waves, while new ones show fresh ST changes and Q waves in different lead groups. The ECG shows loss of normal R wave progression with QS complex in chest leads V1 to V5, as well as QS waves in leads 2, 3, and AVF.
Some heart attacks are silent. Q waves may reveal past MI when the patient never had classic chest pain. Right bundle branch block makes diagnosing MI easier because Q waves remain visible. Left bundle branch block is trickier. Look for Q waves or ST changes in V4 to V6 to detect a hidden MI.
Atherosclerotic causes of STEMI include anomalous erosion of coronary artery, carbon monoxide poisoning, cardiac trauma, coronary artery dissection, coronary artery embolism, coronary artery spasm, Kawasaki disease, myocarditis, pulmonary embolism, and Takotsubo syndrome. ASTEMI shows ST elevation and often Q waves, indicating full thickness heart muscle damage. NSTMI usually shows ST depression or T wave inversion, with injury limited to the inner heart layers.
The inner layer of the heart is most vulnerable to low blood flow. Subendocardial ischemia shows ST depression in many leads, while leads AVR may show ST elevation, the opposite of a classic STEMI. During angina, the ECG often shows temporary ST depressions that return to normal once the pain subsides. But remember, a normal ECG during pain doesn't rule out underlying heart disease. Exercise testing helps reveal hidden coronary artery disease. If ST depression of 1 millimeter or more appear during exercise, especially with chest pain, it strongly suggests ischemia.
The ECG shows physiologic ST segment depression that may occur with exercise. Also notice the J junction depression with sharply upsloping ST segments.
A non-Q wave MI involves the inner heart muscle and shows persistent ST depression or deep T wave inversion. Q waves are usually absent, but enzymes confirm actual heart muscle damage.
The ECG shows marked diffuse ST depression in leads 1, 2, 3, AVL, AVF, and V2 to V6 in conjunction with ST elevation in leads AVR, consistent with severe ischemia and presence of multivessel disease. Some patients with myocardial ischemia may show slight T wave flattening or minimal T wave inversion due to any physiological change, drug effect, pulmonary disease, pericardial disease, cardiomyopathies, or electrolyte or metabolic abnormalities.
Prinzmetal angina occurs due to sudden coronary artery spasm. Unlike typical angina, it causes temporary ST elevation and often happens at rest or during night. Takotsubo cardiomyopathy mimics a heart attack with ST changes and elevated enzymes, but occurs without blocked arteries. It is often triggered by extreme emotional or physical stress, earning the name broken heart syndrome. Not all ST elevation signal a heart attack. Conditions like early repolarization, pericarditis, myocarditis, ventricular aneurysm, or even hypothermia can produce similar patterns on an ECG. ST depression isn't always due to ischemia. It can also appear in left ventricular hypertrophy, digitalis effect, low potassium, or as reciprocal changes in another area of the heart. Deep T wave inversions may point to severe blockage in the left anterior descending artery, known as Whelan syndrome, but they can also occur with stress cardiomyopathy, pulmonary embolism, or even with brain injuries.
The ECG shows prominent anterior T wave inversions consistent with the high grade stenosis of left anterior descending coronary artery, known as
LED T wave pattern or valence pattern. This ECG is of a patient with acute subarachnoid hemorrhage showing deeply inverted T waves with markedly prolonged QT intervals.
Heart attacks can cause mechanical problems like ventricular rupture or shock, and electrical problems like dangerous arrhythmias. Both type of complications can occur together and are life-threatening.
After successful reperfusion therapy, ST segments return towards normal and deep T wave inversions may appear. The presence of accelerated idioventricular rhythm often signals restored blood flow.
If you like this video, give a thumbs up, comment down below your experiences, share this video, and if you are new here, press that subscribe button and hit the bell icon so that you never miss our videos.